Hello everybody, welcome to the APRN pharmacology class. This week we will start with some APRN role regarding prescribing and basic pharmacology principles. Nurses have been administering medications prescribed by another provider for many years. The knowledge base to safely perform this activity has been an integral part of basic nursing education. With the advent of the advanced practice nurse, the role of the nurse in relation to medications has evolved to include prescribing medications as well as administering them. The prescriber role requires additional knowledge beyond that taught in undergraduate nursing programs. Experienced registered nurses, RNs, often find themselves in the position of discussing what might be quote-unquote the best drug a patient should receive with a physician or other prescribing provider. The RN is an advocate for the patient, and his or her input should be sought and highly valued in the prescribing process. APRNs have a higher level of responsibility related to pharmacotherapeutics than RNs. The nature of this responsibility depends on whether the APRN can prescribe medications. States vary in their laws related to prescriptive authority for APRNs. 28 states and Guam have fully independent prescribing by nurse practitioners. Some states have full or limited prescribing allowed by CNSs. Because non-prescribing APRNs have in-depth knowledge of the drugs used in their specialty areas, their collaboration with the healthcare providers who are prescribing is valuable. In 24 states, the District of Columbia, and Guam, NPs have independent scope of practice and prescriptive authority without a requirement or attestation for physician collaboration, consultation, delegation, or supervision. 11 states have full autonomous practice and prescriptive authority following a period of post-licensure/post-certification supervision or collaboration. The 2010 Institute of Medicine's publication, Future of Nursing, Leading Change, Advancing Health, called for removing scope of practice barriers and allowing NPs to practice to the full extent of their education and training. Each year, there are multiple advances in NP practice across the United States. In the January issue of the Nurse Practitioner Journal and an issue of the American Journal for Nurse Practitioners, present a legislative update providing a summary of each state's practice acts as they relate to titling, roles, and prescriptive authority. As of January 2018, the following were true of NP regulation of practice and prescribing authority. All states have title protection for NPs. Only Oregon has mandated third-party reimbursement parity for NP services. In all but 5 states, the control of practice and licensure is within the sole authority of the state's Board of Nursing. These 5 states have joint control in the Board of Nursing and the Board of Medicine. Scope of practice is determined by the individual NP's license under the Nurse Practice Act of the licensing jurisdiction. Some have a graduated scope based on experience level. New prescribers need to understand that their employment sites may restrict this legal scope of practice, but cannot extend it. General knowledge about the pharmacokinetics and pharmacodynamics of drugs, how to administer them safely, and what to teach the patient is learned in undergraduate nursing courses and subsequently refined in practice. Knowledge of medicine, pharmacology, and nursing intertwine in the NP role. The APRN role requires advanced knowledge about pathophysiology, medical diagnosis, and pharmacology to choose an appropriate drug. The prescriber role requires advanced pharmacology knowledge beyond that taught in basic nursing education. A nurse who is studying to be an APRN will need additional knowledge about prescriptive authority. Does the chosen drug fit within the legal authority of an APRN to prescribe in his or her state? What are the conditions under which the prescription may be written, and how does one correctly write it? What constraints may be in place because of the patient's health insurer or lack of health insurance? Additionally, the APRN needs to be aware of new drugs introduced to the market, medication alerts, and label changes due to post-marketing analysis. Some therapies have traditionally been part of what all nurses teach, and they remain central to the role of the APRN. For example, lifestyle management issues for a cardiac patient, relaxation techniques for a patient experiencing stress, and appropriate exercise for a patient with low back pain or arthritis. Characteristic of APRNs and their practice are consideration of the whole patient, the joint setting of therapeutic goals with other members of the healthcare team, and the inclusion of the patient in each decision about care. This holistic approach remains a central element in APRN practice and is often cited by patients and other providers as a hallmark and distinguishing feature of APRN practice when compared with other primary care providers. Prescribing a drug results from clinical judgment based on a thorough assessment of the patient and the patient's environment, the determination of medical and nursing diagnosis, a review of potential alternative therapies, and specific knowledge about the drug chosen and the disease process it is designed to treat. Is there a clear indication for drug therapy? In the age of healthcare reform and increased awareness of the limitations of drugs, whether a medication is the best option for treatment has become an important question. For example, in treating acute otitis media, a high percentage of infections resolve without intervention. So how does one know that the antibiotic was the cause of the cure? Of concern is organisms' resistance to antibiotics, with antibiotic overtreatment considered a contributing factor to resistance. Before drug therapy is chosen, the indication for and necessity of using a drug should be carefully considered. What drugs are effective in treating this disorder? Several drugs may be effective in treating a condition. So which one is the best for a particular patient? How does one determine best? What are the criteria? The Agency for Healthcare Quality, the National Institutes of Health, and many specialty organizations publish disease-specific treatment guidelines that include both pharmacological and non-pharmacological therapies. What is the goal of therapy with this drug? What is the best drug to achieve treatment goals? The goal may be cure of the disease, and treatment may be short-term in nature. If cure is the goal, troublesome adverse effects may be tolerated and cost may be less of an issue. If the goal is long-term, treatment for a chronic condition, adverse effects, and cost take on a different level of importance, and how well the drug fits into the lifestyle of the patient can be a critical issue. Under what conditions is it determined that a drug is not meeting the goal and a different therapy or drug should be tried? Both the provider and patient should have a clear mutual understanding of what outcome or goal is expected of the medication prescribed. Part of the decision-making process may include when to consult with or refer the patient to a specialist. Are there unnecessary duplications with other drugs that the patient is already taking? The patient's medication history should be reviewed at each encounter to detect duplications or medications that may be discontinued. Sometimes drugs from different classes are given together to achieve a desired effect, and this is a therapeutic choice. It may also be that the provider is not aware of the overlap, especially if the patient is seeing several different providers. Would an over-the-counter drug be just as useful as a prescription drug? Increasing number of drugs are being moved from prescription to over-the-counter status. This may lead to a reduction in cost for the patient, or it may increase patient costs due to insurance no longer paying for the medication. What about cost? Who will pay for this drug? Cost is an issue for several reasons. Many insurance policies do not cover the cost of drugs or only provide partial coverage, so the patient must pay out of pocket. The newer the drug, the more likely the cost will be high based on the manufacturer's need to reclaim research and development cost during the patent period. For an APRN, the sources of drug information expand to include the wide array of professional literature that ranges from well-reputed journals to literature from specialty and professional organizations, a multitude of computerized drug databases, for example, Micromedics, Lexicon, Epicrits. The APRN prescriber needs to evaluate how reliable the drug information is. Hello everyone. Today on topic 1.2, we'll be talking about collaboration with other providers. No single member of the healthcare team can provide high-quality care without collaborating with other team members. Teams are most often comprised of physicians, pharmacists, podiatrists, mental health specialists, therapists, and other providers, including APRNs who are not NPs, physician assistants, and other nurses. Collaboration with physicians has been something of a roller coaster ride for NPs. Early in the development of the NP role, physicians were the teachers in NP programs and accepted NPs as physician extenders. As the role of the NP evolved to clearly indicate that it was advanced nursing practice and as legislation made autonomy of practice possible, the relationship became more adversarial, with the American Medical Association issuing statements regarding the NP and PA scope of practice, often for economic reasons. Although this struggle still continues at the national level, NPs and physicians do work together very effectively on an individual basis and in collegial care teams. In an era of healthcare reform, team members' joint concerns about patient care decisions require them to be allies. A physician's expertise related to pharmacology is based on understanding biochemistry and prescribing for a given pathophysiology. APRNs traditionally approach prescribing drugs slightly differently from physicians. As APRNs prescribe a drug for a given pathophysiology, their nursing background leads them to place equal emphasis on understanding the impact the drug will have on the patient. Patient education is a central focus of nursing and APRN practice. Collaboration with pharmacists requires an understanding of the educational preparation for and evolution of the role of the pharmacist. The profession of pharmacy requires graduate level preparation for all pharmacists with the granting of a practice doctorate, the Doctor of Pharmacy, Pharm.D. Both physicians and APRNs increasingly consult Pharm.Ds for their knowledge of pharmacokinetics and pharmacotherapeutics when prescribing for complex patients. Collaboration with other NPs and APRNs who have prescriptive privileges has two major advantages. On a one-to-one basis, dealing with individual patient issues, NPs and APRNs can share pearls from their knowledge base and collaborate to improve the care of the patient. Collaboration on issues related to scope of practice and prescriptive privilege at the state and national level is critical to obtaining and maintaining the autonomy of practice needed to provide optimal patient care. The focus of the PA's practice is similar to that of the physician, so both the APRN and the PA can benefit from interaction with each other in much the same way as from their interaction with physicians. Key to successful prescribing is having a patient-centered approach, which results in the desired outcomes of improved health and maximized functional outcomes. Prescribing is not a one-sided responsibility. Patients also have a role in the development of therapeutic plans and then following through on those plans. Unfortunately, the problem of poor adherence to drug therapy is widespread around the world. The FDA estimates that between 30% and 50% of patients adhere to their drug regimen. Poor adherence results in more than 125,000 avoidable deaths per year. Intentional versus non-intentional non-adherence. Taking or not taking medication may happen for a variety of reasons and may be intentional or inadvertent. Unintentional non-adherence can be attributed to forgetfulness, especially if it is a side effect of a drug, lack of knowledge, dementia, mental health problems, simple procrastination, or an overextended lifestyle. Not perceiving the usefulness of a medication for symptom resolution or adverse drug reactions are sources of intentional non-adherence. Adverse drug reactions. Real or perceived adverse drug reactions directly affect the outcome of a prescribed drug regimen. If a patient reports a prescribed drug is causing a reaction, then the provider should explore alternative options to treating the problem. Asymptomatic conditions. A variety of disease states are essentially asymptomatic until their later stages. Most can be treated with drugs in the early stages to prevent their progression. However, it may be difficult to convince a patient of the necessity when there is no overt indication of the disorder except the provider's word. 1 out of every 2 Americans has at least one chronic condition. Chronic diseases account for 3/4 of the nation's $1.4 trillion in medical care costs and 1/3 of the years of potential life lost before age 65. Understanding the disease state and the treatment regimen plays a role in adherence. Providing educational material alone, written or oral, cannot ensure that the patient will not have a knowledge deficit regarding the drug regimen that he or she will be adherent. Communicating effectively with the patient who have cognitive impairment, for example, Alzheimer's disease, can be a challenge. Each person has a different constellation of abilities and needs for support in understanding and remembering. Assessing the abilities of each patient is important to maximizing adherence. Patients with psychiatric illnesses may have difficulty adhering to their drug regimen. 3 major factors are involved. 1. Psychiatric illness has a social stigma, so patients may not seek routine care. 2. The presence of symptoms may result in thoughts and behaviors that do not foster adherence. For example, paranoia, agitation, or depression. 3. Finally, the adverse effects of psychotropics, for example, dizziness, orthostatic hypotension, blurred vision, decreased central processing, and confusion, are effects commonly associated with non-adherence. Complexity of drug regimen and polypharmacy. The number of drugs used to manage multiple complex disease processes increases the possibility of non-adherence, adverse reactions, and the chances of a decreased positive outcome for the patient. 32 million Americans take 3 or more medications to treat a variety of ailments. Sensory or mobility challenges. Patients need to be able to read the label and open pill bottles to easily self-administer medications. Large print labels can increase safety for those with visual impairment. The pediatric patient. Achieving full adherence in pediatric patients requires the cooperation not only of the child, but also of an adherent parent or caregiver. Adolescent patients may create challenges given the unique developmental, psychosocial, and lifestyle issues implicit in adolescence. Financial impacts. Costs can have an impact on the availability and willingness of the patient to adhere to drug regimens. Basic needs, for example, food and housing, may take precedence over drugs in planning a monthly budget. Selecting drugs with longer half-lives may reduce the likelihood of drug withdrawal symptoms and the return of illness. For example, fluoxetine, Prozac, a selective serotonin reuptake inhibitor used to treat depression, has a 2-week duration of action, so that missing doses or stopping the drug altogether produces a long taper and gives the provider time to discover the problem and work to correct it. Authors suggest the use of reinforcements such as monetary rewards or vouchers, frequent contact with the patient, and personalized reminders. Educational approaches appear to be most effective when combined with behavioral techniques and supportive services, including reinforcements. The caregiver can provide valuable information regarding the patient's responses to drugs or difficulties adhering to the prescribed medication regimen, including adverse reactions. The caregiver may need one-on-one interventions to help adhere to the drug regimen. By exploring the psychological, physical, and social impact of giving care, the provider is acknowledging the difficulties the caregiver must face every day. Multiple methods can be employed to provide cues to remember to take medications. Some patients use a simple visual cue, such as putting their morning medication near the coffee pot to remind themselves to take their medication when they make the coffee. Pill containers can be purchased with compartments from once daily to multiple times a day dosing, and from weekly to monthly schedules. One-stop shopping for medical care and prescription refills may improve adherence. Larger clinics with on-site pharmacies or even pharmacy-based convenience care clinics may provide the bonus of overcoming barriers to filling and refilling medications. Worksites with primary care clinics have nearly 10% better adherence rates. Patient reports are the easiest monitoring tool, but use caution when determining whether the patient is actually pseudo-compliant. Telling the provider what the provider wants to hear, rather than revealing the reality of non-adherence. There are several medication adherence scales in the literature. However, none is considered the gold standard. Please see the book for more examples. The growth in autonomy and prescriptive authority for NPs and other APRNs is a source of pride for the profession. More states are broadening and expanding the legal, reimbursement, and prescriptive authority to practice for all APRNs, including NPs. All states recognize the NP title, scope of practice, and prescriptive authority in legislation. Full autonomy for practice and prescribing is gaining momentum. One issue to be addressed in interdisciplinary teams is the level of education of the various providers. Medicine has been at the practice doctorate level for more than 50 years. Pharmacists have moved the level of education to enter their profession to the practice doctorate, PharmD. In 2004, the American Association of College of Nurses, in collaboration with the National Organization of Nurse Practitioner Faculties, published core content and competencies for the Doctor of Nursing practice. The passage of legislation and the adoption of regulations related to reimbursement are evolving, with the Affordable Care Act rollout creating an opportunity for APRNs to address reimbursement parity. However, the reimbursement by third-party payers continues to be a practice barrier for many advanced practice nurses. In 2013, Oregon was the first state to pass payment parity for APRNs. Hello everyone. This week we will start with some review of the basic principles of pharmacology. Pharmacology is the study of drugs and their actions. Pharmacologists, those who study drugs and their actions, consider a drug to be any chemical substance that produces a measurable biological response. Drugs are developed by pharmaceutical companies to help patients and to make money. Pharmaceutical companies will identify a drug target, starting sometimes with ingredients isolated from a plant or organism in the case of antibiotics, with desirable medicinal properties, sometimes with a molecular target identified in the body to produce the desired response, and sometimes with a disease in need of treatment. Drugs approved by the U.S. Food and Drug Administration, FDA, must both be safe and effective and are screened by pharmacologists specializing in various aspects of drug activity. During the clinical stage of new drug development, pharmaceutical companies must establish the safety and effectiveness of new products in humans. Phase 1 clinical trials typically establish biological effects as well as safe dosages and pharmacokinetics in a small number of healthy patients. During Phase 2 clinical trials, new drugs are used to treat diseases in a small number of patients and establish the potential of the drug to improve patient outcomes. If the drug still looks promising, Phase 3 clinical trials will compare the new medication to standard therapy in a larger number of patients studied in populations across the country. New drugs must be at least as good as, and ideally better than, other available therapies. Throughout the process, pharmaceutical companies work with the FDA. After being approved by the FDA, drugs are continuously monitored through post-marketing surveillance, in which health professionals are encouraged to report adverse events, which are studied by both pharmaceutical companies and the FDA. Now we will talk about drug responses in the next few slides. Drugs produce responses as a result of their chemical interactions with living systems. The relationship between the dose or concentration of a drug and its biological response follows the laws of chemistry. The law of mass action defines chemical interactions and forms the theoretical foundation for drug responses that occur through receptors that moderate drug responses. It is simplest to think that drug responses are directly related to the fraction of receptors that are occupied, or bound by a drug. For example, 50% of the maximum response occurs at a blood level or concentration at which a drug occupies 50% of its receptors. But depending on the number of receptors in a tissue and the ability of a drug binding to produce a change in the receptor conformation, far fewer receptors, less than 10%, may be needed to produce a maximum effect. There are two basic types of drug responses, quantal and graded. These responses differ in how they are measured and how they dictate dosing decisions to achieve the desired effect. Graded responses are biological effects that can be measured continually up to the maximum responding capacity of the biological system. Examples of graded responses to drugs include blood pressure, heart rate, diuresis, bronchodilation, forced expiratory volume in 1 second, FEV1, pain on a scale of 1 to 10, and coma score. Quantal effects are responses that may or may not occur. Example of quantal responses to drugs include convulsions, pregnancy, rash, sleep, and death. Expressing drug responses. Pharmacologists show the relationship between dosage or concentration and drug effect using graphs of the dose-response relationship or dose-response curve. Graphs of drug responses will show the response on the vertical axis and the concentration or dose on the horizontal axis. Dose-response curves provide information on the relationship between dosage or concentration and responses for one or more drugs. Drug selectivity. In clinical use, drugs produce both desired and unwanted responses. The level of unwanted responses we are willing to accept typically depends on what we are treating and the type of undesired effect. Patients regularly accept all kinds of adverse effects from cancer chemotherapy when their lives are on the line. Cancer patients tolerate hair loss, nausea, vomiting, and generally feeling miserable because those adverse effects results from killing cancer cells. There are challenges to expressing drug selectivity. The most reasonable way to express selectivity is as a ratio of the dose or concentration producing the undesired effect to the dose or concentration producing the desired effect. Drug responses in the real world. Pharmacotherapy in real patients is different than what has already been described. The placebo effect is a pharmacological effect that is not caused by the active ingredient. Placebos are tablets or capsules that contain no active ingredient. They are sometimes called sugar pills because they used to be filled with sugar. Dose-effect relationships in the real world do not start at the zero response. They start at the response associated with the placebo effect. The level of response increases as the dose increases, but rarely reaches 100%. Instead, the risk of toxicity will limit the maximum dosage, or another drug will be used if there has not been a satisfactory effect. Brand versus generic drugs. New drugs are patented to protect the innovator company for a period during which only it can manufacture the drug. New drugs are given a generic name that anyone can use to market the drug, but innovator companies will create a brand name that only they can use to market their drug. During the years after a drug is released, it is marketed under the brand name, and patients and practitioners often become familiar with the product under its brand name. Once the patent on the original drug expires, other companies can manufacture generic products that are designed to imitate the brand name product. Generic products are supposed to provide patients with the same dosage as brand name products. The FDA rates generic formulations in its Orange Book, and products with an AB rating are considered to be similar enough to use as generic substitutes for brand name products. Almost all drugs act through receptors. Receptors are the large molecules, usually proteins, that interact with and mediate the action of drugs. Receptors are important because they determine the relationship between dose and effect, the selectivity of drugs, and the actions of pharmacological antagonists. Ion channel receptors. Ion channel receptors transmit signals across the cell membrane by increasing the flow of ions and altering the electrical potential or separation of charged ions across the membrane. Ion channel receptors can produce responses with rapid onset and short duration. For example, activation of ion channels by nicotinic receptors is responsible for muscle contraction. Receptors coupled to G proteins. Several guanine nucleotide regulatory proteins, or G proteins, are present in cell membranes. G proteins share a similar structure in which 7 regions of protein span the cell membrane to create a pocket in which drugs can bind and end with a receptor tail inside the cell. Individual G protein receptors have the general G protein structure, but differ in their binding site, the area that recognizes and binds to drugs, and in the intracellular portions of the G protein that control what happens after a drug is bound. Receptors are activated when specific drugs interact with the binding site, producing a conformational change, a sort of twist, in the G protein. Transmembrane receptors. Transmembrane receptors consist of an extracellular hormone binding domain and an intracellular enzyme domain that phosphorylates the amino acid tyrosine. When an active hormone binds to the extracellular binding site, the receptor conformation changes and 2 receptors bind to each other, activating the enzyme and sustaining the effect. Intracellular receptors regulating gene expression. Lipid-soluble hormones can pass through the cell membrane and bind to intracellular receptors. The glucocorticoid receptor resides in the cytoplasm until it binds with a drug having glucocorticoid activity. Binding of the drug displaces a stabilizing protein and permits the folding of the receptor into its active conformation. Enzymes. Enzymes are biological molecules that encourage specific chemical reactions in the body. For example, the enzyme acetylcholinesterase breaks a chemical bond in acetylcholine to terminate its action and produce acetic acid and choline. A different enzyme can resemble these molecules back into acetylcholine. Drugs can stimulate or inhibit specific enzymes. Drug action at receptors. Drugs can do 3 basic things once they bind to a receptor. Agonists, or full agonists, are drugs that produce receptor stimulation and a conformational change every time they bind. Antagonists are drugs that occupy receptors without stimulating them. Antagonists occupy a receptor site and prevent other molecules, such as agonists, from occupying the same site and producing a response. Antagonists produce no direct response. Partial agonists are drugs that have properties between those of full agonists and antagonists. Partial agonists bind to receptors, but when they occupy the receptor sites, they stimulate only some of the receptors so they can act as part agonist and part antagonist. Disease states and receptors. Disease states, or drug treatment, can selectively alter the number of receptors in various tissue throughout the body. For example, hyperthyroidism upregulates or increases the number of beta adrenoceptors, making hypothyroid patients more likely to have hypertension and a rapid heart rate. Non-receptor mechanisms. Not all drugs act through receptors. General anesthetics, sodium bicarbonate, which neutralizes stomach acid, and chelating agents, which bind to and remove metal ions in the blood, are some examples of drugs with actions are based on their psychochemical properties rather than interaction with receptors. Drug-receptor interactions. Most drugs work by binding to receptors. Receptors are located on the cell surface. The drug molecule must fit into the receptor, like a lock and key mechanism. Drug receptor binding. Drug receptor binding is reversible. Drug receptor binding is selective. Drug receptor binding is graded. The more receptors filled, the greater the pharmacological response. Drugs that bind to receptors may be agonist, partial agonist, or antagonists. Hello everyone, today we're going to be covering the topic of pharmacokinetics. Pharmacokinetics is the branch of pharmacology dealing with the absorption, distribution through the body, metabolism, and excretion of drugs. Ideally, drugs will enter the body readily, go directly to their site of action, and have a favorable combination of metabolism and excretion that will make it easy to manage patients, even in the presence of kidney or liver disease. Absorption. Medications produce little clinical effect when they remain inside the prescription bottle. To produce a biological effect, drugs must enter the body. Once inside the body, drugs can interact with various receptor molecules to produce physiological changes that ideally result in clinical effectiveness. Parenteral administration. Medications may be administered parenterally by injection when immediate effect is required, when the active ingredients are destroyed or not absorbed by the gastrointestinal tract or other routes, or when the patient is unable to take an oral medication. A major limitation of parenteral administration is that it requires needles, syringes, and sterile technique. Drug absorption is greatest for intravenous IV injection. A major disadvantage of IV administration is that once administered, the drug absorption cannot be slowed and the drug cannot be removed from the body. Oral administration. Oral administration is the most convenient and common route of administration. In contrast to IV administration, orally administered drugs must go through a number of steps on their way to the bloodstream. Following oral administration, dosages in the form of tablets, capsules, or liquid make their way to the stomach and continue to move into and through the small and large intestines on their way to the colon. Some medications are destroyed by stomach acid after oral administration or are absorbed too rapidly to be convenient. Enteric-coated formulations protect the medication in the stomach and only disintegrate and dissolve when they reach the less acidic conditions of the intestinal tract. Site of administration. Administration of medication close to where it will act has some notable theoretical advantages. When the medications are administered near their site of action, higher concentrations may be achieved while minimizing unwanted effects in other parts of the body. Bioavailability. Because not all of the administered dose may be dissolved, absorbed, or survive liver metabolism, only a fraction of an administered dose makes it to the bloodstream. This percentage of the administered dose that does enter the bloodstream is called bioavailability of the dosage form. Bioavailability is 100% for parenteral administration, but can range from less than 10% to more than 90% for oral dosing. Peak Blood levels. The speed at which drugs enter the bloodstream affects the maximum blood level that is achieved. Rapid absorption leads to higher peak blood levels with a risk of greater toxicity and side effects. Distribution. After a drug is absorbed, it still must reach its site of action to produce an effect. The process of drugs moving throughout the body is called distribution. Distribution of drugs can occur by transfer through the bloodstream and passive diffusion. Properties that affect distribution. Drugs can passively diffuse most readily when they are small and uncharged and also have the right balance between water and lipid solubility. Some of these properties will be related to the drug, for example, molecular size and lipid to water solubility. Others will reflect drug properties as they present in an individual patient, such as pH, the acidity of the environment in which the drug finds itself. pH affects ionization of the drug. Henderson-Hasselbalch relationship. Acidity is an important property of biological environments. Acidity is measured as pH, defined as negative log of the concentration of H+ ions. Lower pH is more acidic. Most drugs contain chemical functional groups, such as carboxylic acids and amines, that exist in a neutral, uncharged form, or as a charged form. The balance between the charged and uncharged forms depends on pH. It is an important principle in pharmacology that passive diffusion through biological barriers occurs most readily when drugs are in the uncharged state. Because the pH of body fluids is limited to a relatively narrow range and the pKa is a fixed property for an individual drug, we can calculate the percentage of charged and uncharged molecules for a drug if we know its pKa. The pKa can be an important property that influences the drug's absorption, distribution, and excretion. Protein binding. Drugs passively diffuse and distribute when they are unbound and uncharged. Drugs can bind to various proteins present in the bloodstream, often called plasma proteins. Albumin is a major protein in the blood and is measured as part of the typical blood analysis. Albumin has a molecular weight of 66,500, which is too large to be excreted by the kidneys in healthy patients, although in renal disease, albumin is lost in the urine. Binding to plasma protein serves several important functions. Drugs bound to plasma proteins can freely circulate in the bloodstream rather than be distributed by passive diffusion from their site of absorption, so plasma protein binding helps normalize concentrations throughout the body. Drugs that are bound to plasma proteins can be protected from metabolism in the liver and excretion by the kidneys, which can extend the period of time that drugs remain in the body. Plasma proteins can be altered by disease states. Patients with poor nutrition may not have the protein building blocks to produce adequate amounts of plasma proteins. Patients with cancer can be undernourished as the cancer cells feed off the body. Plasma protein binding encourages retention of the drug in the systemic circulation. Binding to proteins is also the basis for a number of drug interactions. Drugs bound to plasma proteins cannot interact with their receptor. If a drug is very strongly bound to a plasma protein, then even a small change in the fraction that is bound can have significant pharmacological effects. Transport systems. Drug distribution is also influenced by transporters, membrane proteins that facilitate the movement of molecules across the cell membrane. Transport systems are often directional, and they can transport drugs into influx or out efflux of cells. In either case, the transport system can transfer molecules and create and maintain a concentration difference between two sides of the cell membrane. Volume of distribution. The volume of distribution is a hypothetical value that reflects the volume in which a drug would need to be dissolved to explain the relationship between dosage and blood levels. If we administer a dose of 100 milligrams and the plasma concentration is 2 milligrams per liter, then it appears the drug is distributed in 50 liters. If we administer the same dose and the plasma concentration is 20 milligrams per liter, then it appears as though the drug is distributed in a volume of 5 liters. Metabolism. Metabolism is an important factor in determining drug activity. When drugs are metabolized, they are chemically altered by enzymes into new molecules called metabolites. Metabolism can increase or decrease the onset, duration of action, and toxicity of a medication. The body is a large container of enzymes that catalyze many chemical reactions that are required to maintain life. Metabolism is the process of changing one chemical into another, and the process usually either creates or uses energy. Metabolism of drugs can occur in every biological tissue, but it occurs mostly in the smooth endoplasmic reticulum of cells in the liver. Phase 1 and Phase 2 metabolism. Drug metabolism utilizes two types of reactions that prepare and tag molecules for excretion. Phase 1 reactions, called non-synthetic reactions, involve oxidation, reduction, and hydrolysis reactions, which prepare the drug molecule for further metabolism. Phase 1 reactions introduce or unmask polar groups that, in general, improve water solubility and prepare drug molecules for further metabolic reactions. Phase 1 metabolism can result in metabolites with greater or less pharmacological activity. Many Phase 1 metabolites are readily eliminated, whereas others go on to Phase 2 reactions. Phase 2 reactions are called synthetic or conjugation reactions because drug molecules are metabolized and something is added to the drug to synthesize a new compound. Cytochrome P450. There's a family of enzymes called cytochrome P450 that metabolizes drugs. Each of these cytochrome enzymes is responsible for a single type of metabolic reaction. The most thoroughly studied drug metabolism reaction is the cytochrome P450 mixed function oxidase reaction. This reaction catalyzes the metabolism of a large number of diverse, highly lipid-soluble drugs and chemicals. Cytochromes are organized into numbered families based on their function. For example, the cytochrome 1, cytochrome 2, and cytochrome 3 families metabolize a variety of drugs and steroids. Metabolism and half-life. The rate of drug metabolism depends on the blood levels of drugs in relation to the affinity of the drug for its metabolism enzymes. Most drugs are present at concentrations below their km for metabolism, the concentration at which metabolism is half of maximum. Under these conditions, metabolism is related to drug concentration so that a fixed fraction of drug is metabolized per hour. This is called first-order metabolism and is characterized by a half-life, the time period over which the drug concentration will decrease by half. Competition for protein binding sites. Finite number of plasma proteins. Compete and displace each other. More free drug. Higher risk for toxicity. More drugs may be eliminated. Hello everyone. Today we're going to be covering the topic of excretion. Excretion. Excretion is the process in which drugs are transferred from inside the body to outside the body. The principal organs for drug elimination are considered to be the kidneys, lungs, biliary system, and intestines. Any individual drug may rely on one or more of these sites for elimination, or on a different site, such as skin excretion or excretion into saliva or breast milk. Renal excretion. The kidney is the primary organ of excretion for most drugs. The general theme of metabolism is to produce drug metabolites that are more water-soluble and more easily removed by the kidneys. The kidney can then remove these substances from the plasma and excrete them in the urine. The kidney is exceptionally efficient at what it does. Approximately 125 milliliters of blood flows through the glomeruli in the kidneys per minute, called the glomerular filtration rate, GFR, which is an important measure of renal function. Glomerular filtration is the first step towards production of urine containing excreted drug. Filtration preserves plasma proteins while removing free drugs and other waste products from the plasma. The large volume of fluid filtered through the glomerulus is an ideal vehicle for drug removal. As the ultrafiltrate is formed, drugs that are free in the plasma and not bound to plasma proteins or blood cells are filtered. Filtration may be slower for large molecule drugs because of the size of the pores through which filtration occurs. Very large drugs may not be filtered at all. The pores of the glomerulus contain a fixed negative charge, so filtration may also be affected by drug charge. Factors that affect renal excretion: kidney function, age, hydration, cardiac output. Biliary excretion. In addition to metabolizing many drugs, the liver secretes about a liter of bile each day. Drugs can enter the bile and be excreted into the intestinal tract when bile is released to help digest food. Only small amounts of drug enter the bile by diffusion. Instead, biliary excretion contributes to removal of some drugs. Some drugs that are excreted in bile can be reabsorbed in the intestine. This creates a phenomenon called enterohepatic cycling, in which the drug is excreted in the bile, absorbed from the intestines, and then excreted in the bile again. Pulmonary excretion can occur for any volatile material present in the body. Pulmonary excretion is important for anesthetic gases such as nitrous oxide. Pulmonary excretion is also important after alcohol consumption. Ethanol distributes throughout the body and is readily excreted each time we breathe. Pulmonary excretion is also important for volatile ketones, which are produced in patients whose diabetes is poorly controlled. Substances can be excreted through the skin, although this is often a minor route of elimination. The skin has a large surface area through which excretion can occur. Drugs may be incorporated into the hair and can be excreted through the sweat glands. Excretion of drugs into sweat and saliva is of minor importance for most drugs and depends on the diffusion of uncharged drugs across the epithelial cells of sweat and salivary glands. Interestingly, some drugs excreted into saliva can produce changes in taste. Excretion into saliva might help explain part of the pharmacological action of certain drugs, such as antibiotic erythromycin, when used for throat infections. Drugs can also be excreted into the breast milk of nursing mothers. The concentration in the breast milk depends on drug properties such as lipid solubility and the degree of ionization. It can also depend on an individual patient's particulars, such as the extent of active secretion into breast milk and the blood level of the drug in the mother. Low molecular weight drugs that are unionized can passively diffuse across the epithelial cells of the mammary gland and enter the breast milk. Because breast milk is more acidic than plasma, it tends to accumulate basic drugs. Infants can be exposed to drugs through breast milk. The risk to the infant from drug exposure in breast milk depends on the amount and type of drug involved and the ability of the infant to metabolize the drug. Breastfeeding is discouraged when there is a potential for drug toxicity in the infant. Hello everyone. Today we will be talking about federal drug law. In this section, we will talk about the following topics: federal drug law, controlled substance misuse, state law, ethical aspects of prescribing, and nurse practitioners outside the United States. The Food, Drug, and Cosmetic Act of 1906 was the first federal law designed to protect the public by restricting the manufacture and distribution of drugs. The law designated that drugs must meet official standards for strength and purity, and prohibited the manufacture of adulterated or misbranded or poisonous or deleterious foods, drugs, medicines, and liquors. Because the law focused primarily on how drugs were ultimately labeled or branded, it did not broadly prevent the manufacturing of unsafe or ineffective medications. In 1937, a manufacturer marketed an elixir of sulfanilamide that used diethylene glycol as a solvent for the new antibiotic. Because its pharmacological effects were not tested, its toxicity went unnoticed until reports of more than 100 patient deaths were collected. The public outcry for new laws resulted in the Federal Food, Drug, and Cosmetic Act of 1938. This act had three basic principles that restrict drug adulteration, misbranding, and the interstate commerce of an unapproved drug. It also created the FDA. As a regulatory agency, the FDA was initially charged with enforcing new laws requiring that drugs be checked before going to market. From 1938 to 1962, the approval of new drugs was based on safety. In the early 1960s, the use of thalidomide by women in the early stages of pregnancy resulted in the birth of hundreds of deformed babies in Europe. A tragedy of this scale was avoided in the United States because the drug was not approved for marketing. The situation spurred the passage of the Kefauver-Harris Amendments in 1962. These amendments required that both the safety and efficacy of a drug be proven before it is marketed. In addition, the act required that all drugs marketed from 1938 to 1962 be evaluated for efficacy. Two additional acts have had considerable influence on improving drug availability and encouraging development of drugs benefiting patients with rare diseases. The Orphan Drug Act of 1983 fosters orphan drug development for diseases so rare that the usual approval process would take decades to complete. The Drug Price Competition and Patent Term Restoration Act of 1984 expanded the number of generic drugs suitable for an abbreviated new drug application. This makes it possible for drug companies to market generic versions of drugs by providing bioequivalence rather than duplicating the clinical trials needed for initial drug approval. Another significant legislative act was the Pediatric Research Equity Act, passed in 2003. This act, referred to as the Pediatric Rule, authorized the FDA to request pediatric studies of already marketed drugs or require studies by others if the manufacturer refuses. Since the passage of the Pediatric Rule, several drugs in common use for children were removed from the market because their safety and efficacy had never been tested in pediatric subjects. After several deaths related to fungal meningitis from contaminated compounded products, Congress enacted the Drug Quality, Safety, and Security Act in 2013. This act enabled enhanced security provisions within the drug supply chain, including those of compounded drugs, to trace drug distribution and recall in the event of a harmful product reaching the market. The FDA regulatory jurisdiction over drugs encompasses the standardization of nomenclature, the approval process for new drugs and new indications, official labeling, surveillance of adverse drug events, and methods of manufacture and distribution. The classification of a drug as a prescription or non-prescription medication is a matter of federal law. Products labeled with the legend, "Caution, federal law prohibits dispensing without a prescription," are regulated by the FDA and are referred to as legend drugs. The FDA also regulates medical and electronic devices that meet criteria under the 1976 Medical Devices Amendment of the Food, Drug, and Cosmetic Act. Examples of medical and electronic devices include ultrasound imaging equipment, artificial joints, and HIV testing kits. The Federal Food, Drug, and Cosmetic Act provides that the advertising of prescription drugs must conform to the labeling. Any advertisement that describes a drug's use must contain the generic name, the amount of active ingredient, the name and address of the manufacturer, and a brief summary of the prescribing information. The FDA does not regulate prescribing. The U.S. system of new drug approvals is perhaps the most rigorous in the world. On average, it costs a new company approximately $2.6 billion to get one new medicine from the laboratory to the pharmacist's shelf, according to a 2014 Tufts University analysis for its Center for the Study of Drug Development. Preclinical research. The process of synthesis and extraction identifies new molecules with the potential to produce a desired change in a biological system. For example, inhibit or stimulate an important enzyme, alter a metabolic pathway, or change cellular structure. This process may require research on the fundamental mechanisms of disease or biological processes, research on the action of known therapeutic agents, or random selection and broad biological screening. Clinical studies. An investigational new drug, IND, application is required before an investigational drug or biological product can be administered to humans. The FDA has formulated IND regulations for the clinical study of a new drug's safety and efficacy and has divided this evaluation into 3 phases. Phase 1 clinical evaluation is the first testing of a new compound in subjects for the purpose of establishing the tolerance of healthy human subjects at different doses, defining its pharmacological effects at anticipated therapeutic levels, and studying its absorption, distribution, metabolism, and excretion patterns in humans. Phase 2 clinical evaluation is controlled studies performed on patients having the target disease or disorder to determine a compound's potential usefulness and short-term risk. A relatively small number of subjects, usually no more than several hundred, are enrolled in Phase 2 studies. Phase 3 trials are controlled and uncontrolled clinical trials of a drug's safety and efficacy in hospital and outpatient settings. Phase 3 studies gather precise information on the drug's efficacy for specific indications, determine whether the drug produces a broader range of adverse effects than those exhibited in the small study populations of Phase 1 and 2 studies, and identify the best way of administering and using the drugs for the intended purpose. If the drug is approved, this information forms the basis for deciding the content of the product label. Phase 3 trials verify that the acceptable risk-benefit ratio seen in Phase 2 persists under conditions of anticipated usage and in groups of patients large enough to identify statistically and clinically significant responses. To market a new drug for human use, a manufacturer must submit a new drug application, NDA, for approval by the FDA. All information about the drug gathered during the drug discovery and development process is assembled in the NDA. Post-approval research. Clinical experience with a new drug may include no more than 1,000 to 2,000 patients. The detection of rare, fewer than 1 in 1,000 adverse reactions is not considered reliable until hundreds of thousands of patients have taken the drug. There are now 4 types of expedited process for drug approval: priority review, breakthrough therapy, accelerated approval, and fast track. Priority review directs the FDA to review the application within 6 months based on potential significant improvement in safety or effectiveness over current treatment options. Breakthrough therapy is designed to expedite the development and review of drugs that are intended to treat a serious condition, and preliminary clinical evidence indicates that the drug may demonstrate substantial improvement over available therapy on a clinically significant endpoint: irreversible morbidity or mortality, or a serious consequence of illness. Accelerated approval allows drugs to be approved for a serious illness based on surrogate or intermediate endpoints, endpoints that measure lab results or clinical effects, which may be predictive. Fast Track facilitates development and review of drugs to treat serious conditions and that fill an unmet medical need. The legal distinction between a legend drug and an over-the-counter drug is not founded on relative safety per se, but rather involves a regulatory decision on whether adequate directions for the drug's proper use can be written for the layperson. If the FDA determines that adequate directions can be written, the manufacturer is not allowed to identify the drug with a prescription legend. Conversely, for a prescription drug, the manufacturer's directions or FDA-approved labeling, the package insert, is intended for the prescriber, pharmacist, or nurse and provides a summary of information about the chemical and physical nature of the product, pharmacological indications and contradictions, routes of administration, dosages, side effects, and adverse reactions, how the drug is supplied, and any other information pertinent to safe and effective use. The prescription of an FDA-approved drug for an off-label, unlabeled indication may be initiated by patient need. Off-label use includes use of an FDA-approved drug in a dose or route for which it was not approved for, or for a clinical indication other than the FDA-approved ones. Hello everyone, today we're going to be talking about controlled substance laws. The most comprehensive federal drug legislation is the Controlled Substance Act of 1970. This law was designed to improve regulation of the manufacturing, distribution, and dispensing of drugs identified as controlled drugs by providing a closed system for legitimate providers of these substances. All practitioners who regularly dispense and administer controlled substances must maintain and keep on file for a minimum of 2 years accurate records of controlled drugs they purchase, distribute, administer, and dispense. NPs wanting authority to prescribe controlled substances must apply for state prescriptive authority before application for a federal DEA number. Applications for a DEA number may be obtained online through the DEA or through the state regional office. Before applying, it is important to verify with the State Board of Nursing or Pharmacy if a state-issued prescribing number or certificate is also issued separately from the NP license. For many years, the DEA number was inappropriately used for other than controlled substances by pharmacies, primarily to bill insurance or track medications under a provider unique identifier. Concern over this, as well as the plethora of separate numbers used for Medicaid and Medicare billing, led to the development and use of the National Provider Identifier Number, also known as the NPI. The NP should obtain an NPI as soon as it is feasible. The next 2 slides presents the schedules, controls required, and examples of drugs. Schedule 1. Controls required. No accepted medical use. No legal use permitted. For registered research facilities only. Drug examples include heroin, lysergic acid diethylamide, also known as LSD, mescaline, peyote, and marijuana. Schedule 2. Controls required. No refills permitted. Written prescriptions only. No telephone orders. Prescription expires in 72 hours if not filled. Drug examples include narcotics such as morphine, codeine, meperidine, opium, hydromorphone, oxycodone, oxymorphone, and methadone. Stimulants such as cocaine, amphetamine, methylphenidate, and depressants such as pentobarbital and secobarbital. Schedule 3. Controls required. Prescription must be rewritten after 6 months or 5 refills. Telephone prescription accepted. Drug examples: narcotics such as codeine in combination with non-narcotic ingredients, not to exceed 90 milligrams per tablet. Hydrocodone, not to exceed 50 milligrams per tablet. Stimulants that include bensphetamine, chlorpheniramine, and diethylpropion, and depressants that include butabarbital. Schedule 4. Controls required. Same as Schedule 3. Penalties for illegal possession are different. Drug examples include pentazocine, propoxyphene, phentermine, benzodiazepines, and meprobamate. Schedule 5. Controls required. Same as all prescription drugs. May be dispensed without a prescription unless regulated by the state. Drug examples include loperamide and diphenyl oxalate. Prescribers should take precautions with controlled drug prescription pads or paper and information included on the controlled substance prescription to minimize the chance for fraud and diversion for these drugs. The prescription pad or prescription printer paper should be stored in a locked area or a locked drawer on the printer. Prescriptions should never be signed in advance or used as notepads. The prescriber's name, NPI number, address, and telephone number should be printed on the prescription form to allow verification by the dispensing pharmacist. The DEA registration number must be designated on all controlled substance prescriptions, though individual states may permit a pharmacist to write in the DEA number if it is not initially provided. Controlled substance prescribing precautions: date, refills, spell out quantity, fax or electronically transmit any prescription except for Schedule 2 drugs. Opioids such as morphine have legitimate clinical usefulness, and practitioners should not hesitate to prescribe them for acute pain for patients who require analgesia or symptomatic relief not provided by other analgesics. When prescribing opioids, all patients should be evaluated using clinically available tools that have been validated, such as screener and opioid assessment for patients in pain. In developing a pain treatment plan, it is important to consider that the effective dose of any opioid will vary according to the degree of tolerance that the patient has developed. In standard clinical practice, There are many opportunities for individuals to obtain excessive quantities of controlled drugs, either intentionally or as a result of duplicate prescribing, often by different prescribers. The problems and costs associated with misuse of controlled prescription drugs may have an impact on patients and their prescribers. Principles for prescribers related to prescription drug misuse assessment include the following: 1. Acquisition and wide use of chemical dependence screening scales. 2. Early and firm limit setting regarding indications for controlled drug prescribing. 3. Careful documentation of a confirmed diagnosis and the ruling out of chemical dependence before initiating a controlled prescription or drug subject to misuse. 4. Practicing just saying no and feeling comfortable with being firm without escalating the discussion into an argument with the patient. Almost every practitioner has experience with a chemically dependent patient who uses dishonest mechanisms to obtain increasing supplies of controlled prescriptions. Once a scam has worked in a given practice, that scam will continue to surface periodically in that practice until the provider ceases to reinforce it. Drug enforcement investigators and patients who abuse prescription drugs commonly observe that the greater the ease of success with scams and drug-seeking behavior in a provider's practice, the higher the prevalence of drug-abusing patients there will be in that practice. Dealing with scams consists of the following steps. 1. Learning to recognize the common scams. 2. Refusing to give in to scammers. 3. Practicing the skill of turning the tables on a scammer. Prescription altering and forging are frequently encountered scams. Variations include stealing prescriptions, forging blank prescriptions, photocopying prescriptions, and rewriting prescriptions. Hello everyone. Today we will be covering the topic of pressure to prescribe. Another factor that increases the demand for controlled substances is the pressure to prescribe at every visit and the expectation that patients deserve a prescription for something at each visit or for each symptom offered. This process results in two well-known adverse situations. The first is overprescribing of antibiotics and resulting antibiotic resistance, and the second is polypharmacy, especially with older adults. Enabling refers to the powerful instinct practitioners have to do anything medically possible to assist patients with present or potential disability to live at a higher level of function. Unfortunately, the disease of chemical dependence has a bottomless appetite. The definition of enabling also encompasses behaviors on the parts of friends, family members, or healthcare providers who shelter the chemically dependent individual from the adverse consequences of the disease. When you suspect a patient is misusing medications. Communication barriers. Nursing socialization further emphasizes therapeutic patient advocacy, sometimes without the counterbalance of coaching nurses on how to say no and enforce boundary limitations. Therefore, many NPs feel acutely uncomfortable with conflict and interpersonal confrontation. It is obvious how practitioners' fear and avoidance of confrontation play into the hands of chemically dependent patients who have a stronger relationship with the prescription than they do with the practitioner. Communication skills. Practitioners must be able to identify common scams and diffuse them efficiently and effectively. One strategy is to just say no and mean it. A higher level clinical skill is to say no initially and then turn the tables on a patient who demands the prescription. This strategy is based on the clinical fact that patients who demand controlled drugs generally have a pathological relationship with the prescription because of the underlying chemical dependence. Careful charting and documentation habits are essential for prescribing controlled drugs. Document clearly in a progress note the following. 1. Physical evaluation of the patient. 2. Physical evaluation of the patient. 3. Physical evaluation of the patient. 4. Physical evaluation of the patient. 5. Physical evaluation of the patient. 6. Physical evaluation of the patient. 7. Physical evaluation of the patient. 8. Physical evaluation of the patient. 9. Physical evaluation of the patient. 10. Physical evaluation of the patient. 11. Physical evaluation of the patient. 12. Physical evaluation of the patient. 13. Physical evaluation of the patient. 14. Physical evaluation of the patient. 15. Physical evaluation of the patient. 16. Physical evaluation of the patient. 17. Physical evaluation of the patient. 18. Physical evaluation of the patient. 19. Physical evaluation of the patient. 20. Physical evaluation of the patient. 21. Physical evaluation of the patient. 22. Physical evaluation of the patient. 23 2. The diagnosis. 3. The clinical indications for treatment. 4. The written treatment plan. 5. The expected symptom outcomes. 6. Informed consent and agreement for treatment from the patient. And 7. Consultation and or collaboration necessary to meet treatment goals and objectives. These strategies reduce, but do not eliminate, the risk of controlled drug diversion from one's practice. As of 2017, all states have an active or legislatively enabled prescription drug monitoring program, also known as PDMP. A PDMP enables practitioners to query a confidential database of controlled substances statewide to evaluate whether a patient is currently receiving a prescription elsewhere. One tool for defining and implementing treatment objectives is the medication agreement. This written tool can be incorporated into treatment of chronic pain, particularly if long-term management with opioids is indicated. The agreement is not limited to opioid prescribing practice, however. It is advisable to treat medication agreements under a universal precaution model of care, meaning that the NP develops and uses agreements that are expected of all patients requiring ongoing use of medications with potential for misuse. NPs are advised to familiarize themselves with urine, drug, and alcohol screens and their availability, costs, sensitivity, and specificity. In-office rapid screenings are now available that can be done without prior notice to confirm adherence to medication agreement criteria. An example of pain medication use agreement is found in Chapter 44. State law. Federal law establishes whether a drug requires a prescription, but does not dictate who may prescribe. The authority to prescribe is a function of state law. Unlike the uniform nature of federal law, prescriptive authority varies from state to state. States have the authority to license healthcare professionals and may sign an agreement permitting cross-state practice, as in the case with the Nurse Licensure Compact. However, there are no currently implemented cross-state agreements that cover NP practice. State authorization is always required for practice as an NP. The State Nurse Practice Act specifies the exact title that must be used for practice and on a prescription. NPs working in federal facilities such as the Veterans Administration or Indian Health Service need to have a state-based license that governs their scope of practice in that facility, but may practice in a facility different from the state of origin under the same license. Persons practicing in a federal facility are also exempt from fees for DEA registration. The prescription format. A number of directions need to be communicated in writing or verbally to the dispensing pharmacist to complete a prescription properly. Tools such as the Institute for Safe Medication Practices list of error-prone abbreviations, symbols, and dose designations can help prescribers decrease transmission errors. The following are suggestions to provide a complete, safe prescription. 1. Use pre-printed prescription pads or electronic templates that contain the name, address, telephone number, and NPI number of the prescriber. This will allow the pharmacist to contact the prescriber if there are any questions about the prescription. 2. Designate the complete drug name, strength, dosage, form, and number to dispense. 3. Indicate the date of the prescription. Use metric units of measure, such as milligrams and milliliters. Avoid apothecary units of measure. 5. Avoid abbreviations. 6. Avoid the use of as directed or as needed. 7. Include the general indication such as for infection. 8. Indicate dispense as written if generic substitution is not desired. 9. Include the patient weight, especially if pediatric or geriatric. 10. Indicate if a safety cap is not required, as medications will be dispensed with them by default. What may be prescribed? Prescriptions are required for the majority of controlled drugs. State laws may permit the sale of Schedule V controlled substances without a prescription in limited quantities. They are also required for some medical devices, home health, and home testing equipment, durable medical equipment, needles and syringes, and sometimes for Medicaid or Medicare coverage of OTC medications that are required for patient health. Prescriptions are required to compound medications for patient administration in strengths or formulas not otherwise available. State-specific elements. State pharmacy law determines the required format for a prescription. A few states require duplicate or triplicate copy pads for controlled substances. NPs who prescribe in a state with mandated collaboration or supervision may need to indicate the name of and information for this person on their prescription. A state can also designate that a drug is controlled and requires a DEA number or other special authority, even if the federal government does not. Electronic prescribing is well established as a method for decreasing medication error and increasing drug tracking and accountability. Electronic prescribing has been implicated, however, in medication errors. Prescribers may become exceedingly reliant on pre-populated protocols and dosages that may not apply to the individual patient's clinical circumstances. Most electronic health record systems have override features that are easy to implement, and this can be a benefit, but it can also be a danger in the wrong hands. It is critical that NPs who prescribe take responsibility for individually verifying appropriate doses and treatments. If in doubt, a pharmacist may be consulted directly, and many large universities run free consulting services for this purpose. Ethical aspects of prescribing. Informed consent. The notion of informed consent is shorthand for the patient's right to make informed decisions about those things that will affect him or her. Informed consent should be obtained from a patient before all medical interventions, diagnostic as well as therapeutic. A patient may either agree to or refuse a proposed intervention. In both situations, the patient is making her or his own informed decision. Informed consent has 4 critical features. 1. A competent patient. 2. Who has provided adequate information with which to make a decision. 3. And who voluntarily. 4. Consents to a proposed intervention. Prescribing for self, family, or friends. State law varies regarding whether an NP can prescribe for family or friends. For a prescription to be clinically legitimate, a patient must be assessed, and there must be a record of his or her assessment. It is clearly unethical to prescribe for oneself, and many states punish this with significant fines or board action. Although it may be technically legal to prescribe for family or friends, an NP needs to consider whether it is ethical. It is never considered ethical for a mental health provider to engage a family member or a close friend in a clinically therapeutic relationship, whether or not prescribing is involved. Sale of pharmaceuticals and supplements. It is illegal to sell pharmaceuticals that are designated as samples and provided to a clinic for free distribution to patients. Depending on the dispensing laws of the state, it may be permissible to stock and sell limited amounts of commonly prescribed medications within the practice setting.